Alrighty, while we wait for the last few people to join in for today's webinar, I'll introduce myself. My name is Dr. David Kunashko. I'm a chiropractor. I've been practicing for too long, 30 plus years now, 31 actually. And I am the medical director of BioFlex laser therapy. Of course, really it's referred to now as photobiomodulation therapy. Our company is interesting in that we were first established as a clinic over 30 years ago, and the now deceased owner at the time and sort of developer of the equipment, Dr. Fred Kahn, he started to manufacture the equipment, and now 30 plus years later, we are probably the oldest and most, how should we say, experienced manufacturer because of our large base clinic and of course all the healthcare professionals that use our equipment. As a reminder, all of these webinars that I do are recorded and then they're edited. And then we try and do a follow-up email about within a week or so of a link to watch it again. Or if you choose to register and not watch, in case you're actually not hearing my voice right now, you're somewhere else. But if you decide to do that in the future, that's fine. You'll be sent a link to watch it again. And if that fails, which sometimes it does because robots aren't reliable, then you can always go to our website. It's uploaded there as well, bioflexlaser.com. And then you go to support and you'll see past professional and past personal therapy system webinars. All right, so let's begin. I see a few raised hands here. I will just mention that if you have any questions, please feel free to ask them. I will tend to get to those at the very end of the webinar. Type those in the Q&A box if you don't mind. It's easier for me to monitor the one box as opposed to two in the chat. If you haven't done so, let me know where you're from geographically. If you currently use laser therapy in your practice, and your interest level in today's webinar would be great. And by the way, if you ever want to have a certain topic for me to discuss, I'm happy to try and do that as well too. So let me know as well. So today's topic, as I mentioned earlier, is laser therapy or photobiomodulation for shingles and postherpetic neuralgia. It's a very common condition. So we're going to briefly go over the etiology, pathophysiology, and the symptoms associated with these conditions. Obviously, they're one and the same, but one's a complication. The postherpetic neuralgia is a complication of shingles. And then we'll talk a little bit about traditionally how they're treated, evidence-based treatment and perhaps prevention. I'll talk a bit about the vaccination. And then we'll get into photobiomodulation because actually there's a fair amount of research and we have a long clinical track record of treating shingles and postherpetic neuralgia, both in our clinic and with our devices. So we have a lot of experience in this particular disease, which is quite prevalent and can be really affect one's ability to do their activities of daily living. And then I'll get into some of this research and specifically how you're going to use our equipment to treat these conditions. So as we all know, herpes zoster, it's a painful, blistering neural cutaneous eruption. Sounds pretty nasty, and it is. It's in a dermatomal distribution, usually unilateral, and usually it's just referred to as shingles. That's oftentimes how you hear it referred to as. After the primary infection with chickenpox, the varicella-zoster virus, or VZV, because I'm in Canada, not Z, obviously it's usually in the early childhood, not always, but often. And what happens is the virus remains latent, and usually it's in the ganglia along the spinal cord, which is one of the areas you want to treat when a person has this condition, or the dorsal root ganglions or other sensory ganglion neurons. So what happens is, as cellular immunity to this virus decreases, and this generally happens with age or immunosuppression or stress and all these other things, when your body is undergoing all this kind of negative immune system function, then this virus can reactivate, and then it travels along the sensory nerves to the skin, where there's inflammation and causes eruption. Usually there's a prodromal pain first. There's these sensations that usually happens first. Oftentimes they're misdiagnosed and, it's not quite clear what's going on. And then before you know it, there's this nasty rash. Now, what I'm describing there is shingles. So being unilateral, usually it's pretty distinctive and being along a dermatomal pattern. And it's usually along the trunk, so the thorax, along the chest wall, one side or the other, or the neck or the face. It can be internal as well, but typically these are the most common areas. And as mentioned before, there's other symptoms, for example, headache and pain and malaise, and there can even be acute photophobia before the eruptions take place. So the rash progresses from vesicles, you can see on the right here, to pustular lesions, and they crust over and then eventually get resolution of this sort of maculopapular rash. When these vesicles are first breaking out and erupting, they contain high concentrations of the virus, right? So you need to be really careful about how you use your equipment for treating these patients. And I'll walk you through what I would recommend for that as well. So let's not confuse shingles with chickenpox. So the initial presentation of the virus, it's usually through respiratory secretions. We all know that, kids are susceptible to them in schools, that kind of thing. Whereas the herpes-zoster virus, shingles, is a reactivation of this latent virus. Signs and symptoms of chickenpox initially are malaise, a fairly high fever, and a rash. Whereas in herpes-zoster, this neuralgia, dermatomal rash, and weakness of the affected nerve. In chickenpox, it's usually the trunk, and then it eventually progresses to the face extremities and usually all over the body, and even the mucosa. Whereas in shingles, it's typically 50%, they say, is thoracic, and the rest are usually cranial nerves, and then cervical and lumbar spine. In chickenpox, it's they're itchy vesicles. They're not necessarily grouped together. Whereas in herpes-zoster, there's that dermatomal kind of grouping of these lesions. There's redness and swelling and these painful vesicles. So, if you look at this diagram, it's, can follow the bouncing ball here. You get chickenpox, and then the virus remains dormant in these ganglia, sensory ganglia of the spinal cord. And then you get this eruption where the virus travels along the nerve to the epidermis, and then you get these red fluid-filled blisters, I guess you might say, and then eventually they dry and crest over, and you can see the most common areas. Now, this condition isn't typically, fatal, but it can be depending on the background of the patient as well. But mostly it costs a lot of issues with cost to society, and that's because it can be quite debilitating. So these numbers kind of fluctuate, but what I found in my research for this webinar today was that herpes-zoster occurs approximately 30% of people over a lifetime. So that's a high concentration. The annualized incidence, I believe this is from the United States. So, divide that by, well, it's going to be probably the same in most countries, but it's 1.5 to 4 cases per 1,000 people. In the United States, it's up to 1 million. So in Canada, you divide that by 10, maybe 100,000 or so, for example, in Canada. The risk of the disease actually does increase with age, and it starts to become more and more common as people get older, and again, probably linked to a poorer immune system. And it's 8 to 10 times more likely to develop in people 60 years of age or older compared to younger people. 1 or more episodes of herpes-zoster will have developed in up to half of people who are, by the time they reach 85. So like as you get older, your risks just continuously get higher and higher. It's also more common, obviously, in immunocompromised patients, especially those that are suffering from an infection of HIV. There are some potential complications, and the one that is most prevalent I'm going to focus on is postherpetic neuralgia. I'll talk about that. But then you can get secondary infections, you can get even facial paralysis. It can even cause stroke, ophthalmological issues like keratitis and even loss of vision. So it can have some nasty, prolonged side effects. The figures, this is probably a little bit old, but you're looking at billions of dollars in trying to treat herpes zoster and its complications in the United States. So it costs a lot of money to deal with this particular virus. Now, the thing about herpes zoster is that it requires a prompt and quick diagnosis if you're going to have really good outcomes. And the problem is that oftentimes we don't get that, and because it's usually related to the clinical presentation, especially of rashes, to obtain the diagnosis. By the time you get the rash, the virus is already spreading, right? So you get these other symptoms, these prodromal symptoms, and oftentimes, they could be misdiagnosed, right, as migraine headaches or as issues like nerve root impingement or whatever, right? And then next thing you know, the outcome's a rash, and then it's like, well, is it too late to use antiviral medications or whatever the case may be? And I'll walk you through those as well. This prodrome usually consists of neuralgia type of symptoms, pinpricks, sensations that like knife cuts or burning pain, ant crawling, itching. There's different ways of describing it. People do experience it a little bit differently as well. Again, remember, if you have any questions, please let me know in the Q&A box. I'll get to those as I go along. But one of the most common debilitating sequelae of shingles is postherpetic neuralgia. And essentially, this is defined as pain that persists more than 3 months after that initial rash has healed up. So you get shingles, the lesions heal up, and the pain associated with it in that dermatomal region does not dissipate. Sometimes it gets even worse, and it can be prolonged for a long time. As has been described as unrelenting, sharp, burning, stabbing pain. And obviously it's going to interfere with everything from sleep and work and normal activities of daily living. Incidence-wise of PHN, they say approximately from 18% at 50 years of age to 33% at 80 years of age. And approximately 30 to 50% of patients experience this condition for more than 1 year. So that's why it's really important to treat it early. And there's actually a paper I'll discuss on using laser therapy on the first onset signs of shingles to reduce the occurrence of PHN. Of course, there's a vaccination too. I'll talk about that as well. So again, you get shingles in the early stage, in the late stage, you can see it healing up. And once it heals up, in some patients, they then have this persistent postherpetic neuralgia. And again, it's usually around the thorax, right? So several studies have shown that PHN can last even up to 10 years. In addition to causing pain, it can lead to all sorts of issues like social withdrawal, depression, physical disability, and so forth. So as I mentioned before, there's a big cost to society for this condition. Unfortunately, to date, there's really no single effective treatment when you're treating PHN. Shingles is a different story. I'll talk about that. But for PHN, it's really tough. They have it, and then they're probably going to get PHN, and it varies as to how this is going to manifest, right? They've used systemic glucocorticoids, antiviral drugs during acute herpes zoster, but the research doesn't necessarily indicate that it's going to improve the incidence of PHN. This was from a paper done, I'll present a little bit later, and it talks about all the different pharmacological treatments And you can see there's antivirals, there's tricyclic antidepressants, there's anticonvulsants, topical and intradermal agents, for pain, of course, and opioids. And then you can see there's, I won't go through all of them, but the list of potential side effects, so, and these may or may not be helpful, right? Laser therapy, well, we still need to do a lot more research and a lot more randomized control trials, but certainly we've seen very promising results in both RCTs and case studies and years of using laser therapy. And the bonus with laser therapy or photobiomodulation is that there are no known side effects. It's very safe and relatively inexpensive. There's no drug interaction, so you can use it even if they're taking other medications as well. So there is a recombinant zoster vaccination called Shingrix. I guess that's how you say it. They initially claimed over 90% efficacy, and it is pretty effective. So this is to help prevent the recurrence, to help prevent shingles, right? Not like, so, person has chickenpox, they already have the virus, and this might help to reduce the incidence. Well, it will help to reduce the incidence, but there are potential side effects of the vaccination as well. So you have to take everything into consideration for that, and your risk and your health level and all the rest of it. Certainly immunocompromised individuals, people that are quite elderly, maybe more prone to the virus, that kind of thing. So the timing of the vaccination and so forth is probably important, but it's usually given over 2 doses, 2 to 6 months apart. And this particular paper looked at the real world numbers of this vaccination, because you have the numbers put out in a pristine environment that the drug company does, and then you have real world numbers. And what they found was that the overall effectiveness was actually closer to 70%, and 57%. Well, 70% of 2 doses were used, and if just 1 dose, it was dropped down to 57%. So a fair amount lower than what they were actually saying. And sorry, let me go back to that. And my point with this is that this vaccination may well be a good way to prevent shingles. It's not going to necessarily prevent PHN in someone that has shingles, right? It's meant to prevent shingles, which, if you don't get shingles, you don't get PHN. So one and the same, I guess. But we all know that many people don't get this vaccination. In Canada, anyhow, it's not covered, I believe, by provincial healthcare funding. So you do have to pay for it. It's out of pocket. So you can imagine, depending on your socioeconomic status, I mean, a lot of people can't afford it. They don't know about it or what have you, right? So, and because it's paid out of pocket, a lot of people don't end up getting it as well. I mentioned earlier that we have BioFlex has a long history of treating PHN and shingles. This was a paper that was published in Practical Pain Management Journal. It's getting a little bit old now. It's 8 or 9 years old, but still certainly relevant. You can see the authors there, including Fred Kahn and Randy Merrick, a medical doctor in Virginia, as well as Fernandez Saraga, who was once our director of clinical research a few years ago. You can see the link down here. You can get the paper for free if you'd want to check that out. So we know that PHN results, it's an inflammatory issue. So it results in inflammation of the sensory root ganglia and the dermis of the associated dermatome. We know that photobiomodulation can help mediate analgesia, so help reduce pain. It does this in many mechanisms that have been studied, including the release of local neurotransmitters like serotonin, a release of endorphins, and decreasing inflammatory mediators like prostaglandin E2 and bradykinin, which cause pain. So inflammation that causes abnormal stimulation of the nerves can be decreased with photobiomodulation. PBMT is known to increase anti-inflammatory cytokines, specifically interleukin-10, along with decreasing of pro-inflammatory interleukins or cytokines like TNF or tumor necrosis factor and interleukin-1B. There's quite a few. And this helps the inflammatory process to be resolved faster, therefore reduction of pain faster. So it's about managing these patients with their pain levels in a safe type of treatment. Let's review some of this research that I've talked about. This was a pilot study. So again, we have to be leery of pilot studies because it's not a full-blown RCT, but it's still valuable information. In this particular paper, they used red only. So 650 nanometers is in the red wavelength, treating patients that had postherpetic neuralgia. They looked at 15. Their ages ranged from 42 to 82. And this is important. They had 16 sessions over 8 weeks. So on average, about 2 sessions a week. I'll talk about the treatment plan I do recommend for these patients. Initially, I'd prefer 3 times a week, but minimally twice a week. And then they did a VAS, and they also did other statistical analysis to track their symptoms. And so what they found was that the final pain score was 0 in 11 of these patients after the treatment regime. In 3 of the patients, it went down to 2 to 3. And then in one particular patient, it was still a 4 on the VAS. So overall, in this pilot study, they showed that LLLT, which is the old terminology, low-level light or laser therapy, now it's PBMT, proved itself to be, in this case, an excellent therapeutic modality for relief of pain, which is the #1 chief complaint in these individuals. Now, this is a double-blinded crossover trial using laser therapy for PHN. In this case, they looked at 25 subjects. They all had PHN of greater than 2.5 years of duration. That's why I like this paper, because even though it's dated, all these patients had PHN for greater than 2.5 years. Okay, so it's not like you're treating someone and then it's like, oh, that was a natural, course of that infection or what have you. We're looking at people that have had unrelenting symptoms, PHN, for 2.5 years. It's there, okay? And these patients were elderly, well, getting older, average age 69, so, getting up there. I'm not quite there yet, but God, that's pretty soon, I think. They used gallium aluminum arsenide, 830 nanometers. Just so happens that's exactly what we use in our laser probe, 830 nanometers, the source gallium aluminum arsenide. Now, our laser probe goes up to about 180 milliwatts. Of course, you can tune it or change the power if you wanted to 60 milliwatts. They did 16 seconds per point, and the overall treatment when they were doing that on each point was 45 joules per centimeter squared. So in this particular trial, they all had 10 out of 10 pain. It was a double-blinded crossover trial, as I mentioned. And all the patients who received treatment demonstrated a reduction in the pain severity with a mean of 74% and a reduction in pain distribution, that is the area of the pain, with a mean of 64%. And most importantly, the follow-up 3 to 6 months later after therapy revealed that 80% of the patients had maintained their improvement. Okay, so it wasn't a short-lived kind of scenario. So it helped this inflammation and issue start to resolve on a permanent basis, right? Because if it was temporary, like an opioid or a medication, topical, you're looking at temporary relief only. That's all it's trying to do. Another paper was, this is a bit more recent, and it talks about early application of LLLT or PBMT to reduce the incidence of PHN. So this is a retrospective study, again, not as great as an RCT. So again, you have to always look at this with, you don't want to be biased, right? This is all part of the information process, but again, it's indicative that it could be helpful. So they looked at the incidence of PHN at the first, third, and 6 months after the rash outbreak in 3 groups. So they had an acute group that received laser therapy during the first 5 days. They had a subacute group that received laser therapy 6 to 14 days after the eruption, and then a control group who did not receive laser therapy. Okay, so again, the rash occurred, and then within 5 days, treatment. So the sooner you can treat, the better. So the results showed that there were 48, and 154 patients in the acute, subacute, and control groups. And after they adjusted for different factors, including age, sex, and use of antiviral drugs, the incidence of PHN was significantly lower in the acute group versus the control group after 1 month, 3 months, and 6 months. The subacute group didn't have as good an effect and only had a lower incidence after 3 months when compared to the control group. So they concluded that by applying photobiomodulation or low-level laser therapy within the first 5 days of the herpes zoster eruption, this significantly reduced the incidence of PHN. I see you have some questions, which is great. I do kind of ask you to stick to the topic. I see someone asking about Parkinson's, and I can appreciate you have lots of questions for me, but you know, I have to try and I want to try and stick to the topics at hand. So questions about this specific topic, I'd appreciate. So LLOT may have the potential to prevent PHN, but obviously you need better and more randomized control trials. All right, so how are you going to use the equipment? Well, if you have our equipment, you already know this as far as what the equipment looks like, but if you don't, we use 2 types of pieces of hardware. One is a large surface array. These are high-powered LEDs. They're not lasers. And we also have lasers or laser probes, we call them. We have both red and near-infrared laser probes as well. We usually use them in combination because a large surface LED array is really good to affect a large surface, obviously, of skin and a little bit deeper, whereas the probes, the infrared especially, can get deep into the dorsal root ganglia or around that area, which is really important as well. The array won't do that as much because they're LEDs and not as intense light, but they do a great job of treating the nociceptors and the sensory fibers just deep to the dermis, right? That's why they're so good. You don't need a laser for that. Over the years, we've developed a protocol to treat herpes zoster and PHN, and this is kind of what it looks like. It's developed into 3 different levels of intensity. We always recommend starting off with the first level of intensity. So that when you first do the treatment, you're going to use red light on that large surface dual plus array. It could be 180 diodes or 240 diodes. We have different sizes. And you can see here the red is being pulsed out at 50%, 50 hertz, and the overall power is set at 50%, which is a duty cycle. 6 minutes on one area. Now, how many areas you're going to treat, that kind of thing, I'm going to talk about very shortly. And you can see there's a progression. So typically how you would attack this type of issue is start treating and seeing the benefits. And if you're not, the patient isn't experiencing pain relief and you're not visually seeing objective improvement, then you can start to increase the parameters into stage 2 and stage 3 if necessary. So a few key points. And again, I'm using the thorax because this is the most common location. You want to treat over the affected spinal cord area, over the spine. You want to treat along the sensory nerves and the dermatome. And oftentimes that will require several placements of the dual plus array. So I would say minimally 3 placements are required, sometimes more, maybe sometimes less, depending, where it is and the extent of the issue, but you always want to treat over the spinal cord as well. So again, always obtain maximum benefit out of that first treatment stage before going on or increasing the parameters. Don't advance too rapidly. You need some time for the patient to respond. So as I mentioned, you wanted to sort of divide your time or your treatment over the spinal cord, the nerve roots, the peripheral nerves, and the dermatomal involvement as well. I keep emphasizing it's important to treat over the source of the virus at the level of the spinal cord and the nerve roots. Initially, the probe is automatically sent to 30% power, so it's relatively low. This kind of mimics close to what they used in that study as well. If you have a red laser probe, which is not standard equipment, but you can add that on, it's really effective for pain because red light doesn't go very deep, but it really accumulates superficially, and especially where the nerves are and the lesions. So it's really helpful. Infrared will be spreading out a much farther depth, so the concentration of photons isn't as great, but the red only goes much shallower depth. So there's a lot more photons. I'm using my hand gestures a lot more photons in a smaller volume of tissue, which will have a greater effect on pain reduction and improvement of the actual lesions themselves. So if you don't have a red laser probe, I really do highly recommend it because it is very beneficial for treatment efficacy, not just for this condition, but others as well. So we want to be very careful about hygiene techniques, post sterilization of the treatment heads, wiping them with a clinical grade disinfectant wipe. You can use watered down alcohol, but that's not my preference. I prefer using clinical grade wipes, not like SanaWipe or what have you. Don't use Lysol, perfume, domestic stuff. Use antiviral, use the good stuff that's going to kill 99.999% of all viruses and bacteria. You'll also want to apply a transparent wrap. You can do it directly on the patient, or you can wrap it around the treatment head. 3M makes products like this. Technically you could use saran wrap. You do want to be very careful that it's in an environment where it's not contaminated, that kind of thing. But preferably we do recommend a 3M, I forget the name of it, 3M something derm transparent wrap. You can look that up as well. So usually I recommend treating 3 times a week. If it's really acute, treat daily for several days, even 3, 4, 5 days in a row before you go every other day. Then you may have to treat 3 times a week for several weeks, maybe a couple of weeks, maybe 3 weeks. It all kind of depends how they're responding. Then go to twice a week, and typically going to keep up with twice a week until they're pretty much asymptomatic and things are looking pretty good. Just one case study. We've done lots of them. This is a 50-year-old female. You can see an acute breakout in the lumbar spine region. And you can see that following this sort of pattern, this dermatomal pattern. Initial presentation, 5 days of treatment. That was consecutive days of treatment. You can see that's already really quick healing over. Usually it takes 3 to 4 weeks for these things to occur. To get to this stage. And then after 15 treatments, so this is approximately a month, the lesions were pretty much healed. You can still see rubor and some redness there, but pretty much the symptoms at that time were abated. So that's just one sort of case study or example I can share with you. Next webinars are on treating arthritic symptoms using your personal therapy system device. So this is for consumers at home that may have a personal system, or for practitioners that perhaps recommend them to their patients. Or if you want to learn more about that, then you can tune into this one. And then I have one on post-surgical healing in November, a professional webinar. I'm not sure if you guys are all aware, but we have a huge randomized control trial going on with McMaster University for post-surgical wound healing, post-C-section, cesarean section in females. got a huge grant for this. It's being done at 2 different sites, two hospitals. At McMaster, over 200. We hope to have over 200 subjects for it as well over the next couple of years. So I'll share a little bit of information about that as well on this particular webinar. Thank you so much for joining. My email is below, and I'll get to the questions now. So if a patient has recovered from shingles, do you still recommend the patient to use cold laser therapy for prevention purpose of reactivation of shingles? So once recovered, the idea is that, well, that the virus will be there. And I haven't seen any research or follow-up where they continue to do treatment to prevent the recurrence of PHN. Only when it's already broken out do we know that if you do it quick enough that you'll actually get a reduction of PHN. So it's hard to say if, maintenance treatment would make a difference. I couldn't really say for sure. We don't do that, so I wouldn't necessarily say you could do that with any assurity. Do you think the fact that kids are now getting vaccinated against chickenpox limits adults being exposed to the virus, repeatedly making shingles more common as we gradually lose our immunity? So I'm just trying to understand this question. Do you think the fact that kids are now getting vaccinated, adults being exposed to the virus? I mean, so I mean, shingles doesn't occur due to exposure to the virus. It occurs because you already have the virus within you. So there's that. But adults can get chickenpox if they never had it as a kid and were vaccinated or what have you, or the vaccination, or their immunity is regressed as well too. Would cold laser treatment reduce the duration of the prolonged PHN? Yeah, so that's the idea. So with those studies and this research is showing, and I think obviously I covered that is very helpful in reducing both the pain and the duration of PHN, especially if treated early. Is it possible to have shingles without the rash but still have? Someone's calling me for clinical support. I guess they don't know that I'm doing a webinar. Still chiming in there. Let me try and okie doke. If you don't know, we offer clinical support. You call me anytime other than when I'm doing webinars. Yeah, so have shingles without the rash, but still have the neural issues. I believe there's some variations in there, and that is possible. Where can I learn about the effects of photobiomodulation on Parkinson's? Again, I don't mind answering that question. I would prefer an email, and I can share you some research and information on that. Does the use of antiviral drugs create any contraindications to using PBMT? And the answer is no to that. There are also effects of homeopathic medicine on herpes, HSV 1, 2, and herpes. Yeah, I can't. So as far unfortunately, I'm not an expert in it. I can't really comment on that. It's not my expertise. So unfortunately, I can't comment on that. Are you going to? Hi, Mike. A question from Mike Sider. Are you going to get a lot more pain reduction with the red probe as compared to the red array? I would say yes, because the amount of photons in a small area from that laser probe, from that red laser probe, would be significantly more than the red array. The red array is really effective, but that red laser probe takes it to another level as far as pain reduction. And what it also really helps to do is it just concentrates on specific areas that are really bad. And that's why I like that red laser probe. Is it possible to get herpes-zoster print out of our... Oh, okay. So if you'd like, many of you may or may not be aware, but the protocols that we have, like we've developed a lot of protocols, but they're not all in the software, the manuals. And the reason for that is that we don't have approvals in all different countries for all of them. And so therefore we can't put them in the software, but we can make them available, not so much like after the fact. Through Dr. Khan published a clinical, his own sort of manual. So it's not technically part of our system, but it's a reference work of his work. So if you'd like that, and it has other protocols perhaps that you may not have in your equipment, just shoot me an email and I'm happy to share that document with you as well. Wonderful. Thanks for joining me today. I really do appreciate your time. I see some questions in the chat box. Are all these presentations available for future viewing? They're on our website, uploaded when they're finished within a week. Just go to support and then you'll see professional and personal therapy webinars. There's a question about genital herpes and prevent its recurrence. There is some work done on that as well too, and I believe it's also very helpful for that as well. Our clinical trial. So our clinical trial at McMaster University is now officially underway. We received a large grant along with McMaster to do this trial. I'll share this with you during the webinar coming up in a couple of weeks. Thank you everyone for joining me. I really appreciated your time, and take care.